concentrating on NHS waiting times, like what are the reasons and potential solutions for this problem. Next slide, please.
These are the
Uh,
things we're going to be
yeah.
talking about today. We have three reasons for the waiting list and three potential improvements we can be making to improve those waiting lists. Next slide, please. So the first reason for the waiting list are staff shortages, starting with reduced capacity for patient care, which is when there are fewer staff, so fewer appointments can be carried out, fewer surgeries because there aren't enough doctors, nurses, or allied health professionals, and the NHS can't run all the available clinics and theatre lists or diagnostic services. This leads to backlogs increasing as patients continue to be referred, but fewer and fewer are treated or diagnosed as they need to be. Another cause of, no, sorry, another consequence of staff shortages is delays in emergency departments and admissions. Ambulance handovers are delayed because there aren't enough doctors in the A&E to be looking at patients, and referrals from the A&E to other parts of the hospital are all delayed as well. There are also a lot of bed blocking caused by this because less staff means there's less nurses and doctors which can look at the patients and see and deem them fit for being discharged from the hospital. There's also an impact on planned care with cancellations and rescheduling happening a lot, especially with surgeries. Staff shortages mean that the outpatient appointments and surgeries have to be postponed and means longer waiting times for any care the patients have to be shown. There are also longer diagnostic delays because we can't like analyze x-rays and there aren't enough radiologists or lab staff to be looking at the results of a patient. There's also another note, there's workforce burnout and turnover with high stress levels from the overworked staff. This has an effect of a cycle because as more staff are overworked, more and more of them leave, which means the ones remaining get put under more and more pressure. Uh, there's also recruitment and training delays, which means that training doctors and nurses ages and short-term shortages can't be quickly fixed because you can't just pull a doctor or a nurse out of med school and tell them to do a job. There is also challenges with international recruitment because of visa and regulatory barriers, as well as global competition for health professionals because everybody needs the same sort of doctors. Supporting data for this is that 110,000 vacancies are in the NHS alone, including 8,000 doctors and 40,000 nursing posts. There's a waiting list for elective care in England, which includes over 7.5 million people, according to 2024 figures, which is the highest on record right now. Staff shortages are a top concern raised by NHS Trust due to all of these factors, because not only is it bad for the patients, it also means that we have more and more people leaving the NHS, which we don't want. Next slide, please.
The UK's aging population is another major significant factor contributing to the lengthy NHS waiting list. So people tend to live longer and they're more likely to develop a chronic health condition, which could result in having a deteriorating impact on their health, which requires ongoing medical care and assistance. This increasing demand would put further stress and pressure on the NHS system. And according to the data from the House of Commons Library, in England, waiting list for hospital peaked at 7.8 million people in 2023. In 2015, 54% of people aged over 65 had two or more health conditions. By 2035, researchers estimate projections could rise to 67.8%. So living with multiple conditions has been shown to lead to greater complexity in care and a higher risk of hospital admissions and readmissions, longer hospital stays, delayed discharge, and generally a lower quality of life. Alongside the NHS and people profession needs to respond to the changing nature of work, including people's expectation from their employment. So demographics within the workforce are changing. Working lives are lengthening as the UK population ages. As the UK state pension age rises, more older people will be in employment. So by 2030, the number of economically active people aged 65 and over is projected to increase by 1/3. So these factors from working could perhaps play a role in developing a life-threatening chronic illness. So these interconnected factors could potentially put immense pressure and strain on the NHS system and the staff. Yeah, next slide.
So the NHS definition of bed blocking is the state where patients who no longer require acute hospital care remain in hospital beds due to a lack of appropriate social care arrangements. So, for example, they can't go home because there's not enough support for independent living, or there aren't enough care home placements. Next slide, please. Yeah. So a case study we'll look at is bed blocking during COVID. This was significantly impactful compared to the regular level of bed blocking because before COVID occurred, 5% of the NHS beds were occupied by patients who were waiting to be transferred, not because they needed further care. Whereas during COVID, this increased to 13% because they needed to go to social care or community settings. There's multiple consequences of this. So during COVID, it was that 7% fewer daily outpatient slots were available per consultant. And COVID-19 intensified existing social care deficits, causing approximately 1 in 8 beds to be blocked. This bed blocking directly hurt both elective and emergency care, leading to the NHS's biggest waiting list on records. So 12% fewer surgical procedures were happening per surgeon and 18% less emergency activity per clinician. This wasn't because there was less emergencies, but just because they couldn't facilitate to cater for them. The waiting list soared to over 7 million before 2023, with 2 million people waiting more than 18 weeks right after the COVID waves. So this is for electives and general surgery. There are further consequences of bed blocking. So not just in COVID, but these are the general consequences. The lack of funding is exacerbating the problem because it's reducing the beds available. And so there's even fewer beds for people who really need them. And elective care procedures have to be stopped or pushed back. So the general sort of rule of thumb in the UK is that 92% of patients wait approximately 18 weeks, but this can be extended to a year because of bed blocking. And the NHS 10-year plan is looking to bring it all back to the 92% waiting 18 weeks again. Also, people have to wait in ambulances when there are no beds, which prevents the ambulances from carrying out their service and helping those that are in critical condition. And that leads to bottlenecks in emergency care, and there's fewer A&D units available. The potential solutions that we're exploring is for the funding to be increased. So in terms of having more NHS beds available, but also more social service beds available so that people can be sent to where they need to go. Usually people aren't sent to where they have to go in terms of further care because there isn't enough to accommodate them. We could also improve social services. So, for example, a 10% increase in local authority care home capacity can cut the social care discharge delays by 6 to 9%. You can also improve support services to help people live at home independently. So that would mean perhaps giving them more online information so that they know what to do, or having a carer initially, even training them so that they feel comfortable at home and giving them regular checkups and monitoring so that they can live independently without staying in the hospital and taking up a bed. You can also increase the employment of carers because if there's more carers, then more people can be sent to care centres and the care homes, freeing up the beds for those who need them in the hospitals.
The next improvement that we can make is through AI. One such improvement is the diagnostic support and speed that AI produces. Uh, AI can read scans faster than humans can in some cases, which means that urgent care can really benefit from this. It can also prioritize urgent cases since it can identify cancers faster and also any other life-threatening abnormalities earlier. An example of this is Kieran's Medical's Mia AI system, which has been used in NHS breast cancer screening trials and shows AI matches that exceeds radiologists in detecting cancers. Another thing that AI can do is streamline administrative tasks. It can automate triage in GP and hospital settings using things like chatbots. It schedules appointments and assigns referrals immediately instead of us having to wait for the referrals to be made or having to call the hospitals ourselves. Um, it also summarizes patient notes for a GP, which means that there's less paperwork burden and that GP can prioritize patients and the time they spend with them instead of having to spend time doing history or making notes themselves. An example of this is UCLH NHS Trust, which trialed AI tools in managing outpatient referrals and appointments, which reduced admin time effectively and freed staff up for patient care. It also optimizes workforce and resources as the AI systems predict staff shortages and surges in patient demand. It also models patient flows, and this helps minimize delays in surgery or A&E. An example for this is NHS England's AI lab, which funded predictive analytic tools to forecast A&E demand and allocated beds accordingly, which meant that bed blocking was less of a problem. AI also supports virtual care and remote monitoring, as remote consultations are supported by summarizing symptoms and patient history in advance, so the GP doesn't have to like look it up and write his own notes on it. It's already done for him and or her, and the GP can just get on with the appointment instead. It also helps to monitor chronic conditions by reducing in-person appointments, which means that the person doesn't need to be inconvenienced by coming into the hospital. And if it's just to a GP, it doesn't have to take up a GP visit for someone else that might potentially need it more, especially if it's a chronic condition that doesn't cause many problems and just needs monitoring. An example of this is remote AI supported monitoring, which has been used in heart failure patients and has been shown to reduce hospital readmissions. There are a few challenges and limitations with this, though, as data quality and bias can exist in AI, since historically NHS data has been based on white males. So anyone other than that might be at a disadvantage due to AI being biased, since AI can really only know what it's been taught and it can't make its own opinions. There's also an integration issues since NHS trusts use outdated IT systems, and this means that AI can't be inputted into the system as easily as we could into a normal computer or laptop. There are also patient safety concerns since over-reliance on AI can be risky if it's not clinically validated. For example, over-diagnosis or underdiagnosis can happen when using AI, since the AI can either dramatize it by identifying something that potentially might not even cause an issue, and or otherwise it might miss things that could potentially cause an issue, but it doesn't identify properly. It also needs staff training, which means it has an economic problem and a time problem, since it takes a long time and a lot of money to train clinicians to interpret and question AI outputs.
Lina, are you there?
Sorry, my mic wasn't working. So, improvement in funding. Improvement in funding solves many issues of NHS waiting times by reducing bed blocking, waiting times, and increasing recruitment. The government is reducing waiting time through funding the NHS £1.57 billion to provide more appointments and treatments for patients. The aim is to ensure patients receive the right elective treatment within 18 weeks, issuing an additional 400 to 700,000 treatments a year. This creates space for 2 million appointments a year. With £1 billion due to 450,000 delayed transfers of patients who have discharged but don't have care arrangements in place, the NHS is supporting to resolve this issue by being funded £2.6 billion in 2023. Along with this extra support for carers and social services are being able to provide support for these patients. This is done through supporting to attain qualifications to become carers whilst providing support centres, community rehabs and places to go for these patients. Next slide, please. To be able to keep to the expected of 2 million appointments a year and the current 7 million demand on the waiting list, as well as the current NHS being at 1.4 million, leaves many vacancies open. This requires more training for many healthcare professionals. And so by 2031, medical school training places will double 50% increase in GP training places, creating training for an additional 24,000 nurses and midwives, whilst also introducing apprenticeships in clinical settings by 2028. By 2036-37, the aim is to build the NHS to a team up to 2.2 million to keep up with the demand in order to help solve waiting times.
So the 10-year plan Fit for the Future. This is just a plan by the NHS which highlights the needs to move patient care from hospital to community and create a shift from analog to digital. This was said by Dr. Rafia Aptab, a GP working at Riverside Surgery, and it said that it will facilitate more efficient and appropriate patient care and therefore help reshape the structure and function of our NHS. So what they're aiming to do is reinvent the NHS as a preventative and patient-controlled system where it will mainly be digital focused. So this makes it more accessible to people who need it, such as the elderly, where they may not be able to access the hospital, and deal with NHS waiting times, which are said to be going down with the shift. The plan was helped shape by 250,000 people, including staff and the public. So it is quite representative of what the people want and how issues can be tackled. There are three fundamental shifts. The first being obviously analog to digital, where there's the NHS app that is said to be created by 2028, where you can self-refer yourself, create or book appointments, deal with your own prescriptions and access your single patient record. This is also known as doctor in your pocket. So it's a more convenient way as to deal with your own prognosis. This may take some time, but it is hopefully going to be a very efficient way to deal with your own illnesses. Furthermore, there are hospital league tables that are going to be implemented, kind of like the medicine league tables that we can see for unis. These will help differentiate different departments and see where care may be more ideal for certain treatments. The last two examples would be the Digital Child Red Book and AI Scribes. Sorry. And then the second fundamental shift would be from hospital to community, where we'd see an increase in GP training, as mentioned earlier, which this would allow for the same day access. So you'd be able to get prognosis within your community, and GPs would be able to create more care plans for further complex needs. This would be aided by a doubling in personal health budgets by 2029, which would rise to 1 million by 2030. With this plan, they aim to build 250 to 300 neighborhood healthcare centers, which are aimed to be opened 6 days for around 12 hours per day. And they are currently in the process of creating these and should be finished by 2029. The last fundamental shift would be from sickness to prevention, where, as mentioned earlier, AI will be deployed. And there is newborn genome sequencing, which is aimed to occur to around 100,000 newborns. Furthermore, there will be surgical robotics from 2026 and are currently being planned to help out at hospitals to create a more efficient, effective process. And there will be free wearables in more deprived areas by 2035, which is quite a long time, but if implemented, should make things more accessible for those who are unable to get or locate hospitals or GPs. More recently, there's been a target on obesity. You may have heard that there's a jab release called Mounjaro, and while it isn't for those who are just obese, it's for those who exceed morbidly obese, so reach the BMI of 40, and the aim is to just see a decrease in these like illnesses caused by excess weight or typical unhealthiness. There are also food advertising rules and labels that have become mandatory, such as the light system, where you have the red light, yellow light, green light, which show obviously the levels of certain aspects of food. Then there's also sales reporting, which will be more so controlled by the government. Well, they'll monitor what's being sold and to what extent. So taxes might be implemented, such as the sugar tax, which is already being seen. Next slide. So there are a few concerns about this 10-year plan. There is a target to save 200 million within 3 years with the app enhanced access, and this should see a reduction in corridor care within hospitals. And obviously, this is great in theory, but since projections are so high and aims are obviously high to reduce the NHS waiting times, there are several criticisms present, including questions on whether this is exactly feasible. Because of such an aging population, there's a larger demand for integration of services. And obviously there's funding clarity. So with NHS England being demolished and it just slowly becoming the NHS, this should be mitigated, but there are people who are worried about where funds are being allocated later on. There are obviously workforce shortages, especially with the strikes being put into place where resident doctors aren't exactly happy with their hours and the funding. And there's also the worry about cross-sector coordination, where public and private healthcare will be incorporated into one, especially with like GPs and hospitals. There are worries about how this will actually be put into place, but there's around 99% of GPs within England that are willing to work with local hospitals, which is obviously a great thing. But to add to that, there are concerns that the NHS is focusing more on rebounding rather than the actual issues behind the high level of cases such as poverty, social care, and staff morale. All of this, which is quite broad and large, and so won't be able to be tackled head on unless there is more funding focused on these areas. Lastly, there's also strikes, as mentioned earlier, industrial action risk, where resident doctors will be striking this month, actually from the 25th to the 30th of July, and this will affect local communities, hospitals, where cases will probably are predicted to rise. So the question we're left with is this 10-year plan worth it? Thanks for listening, and if you've got any questions, feel free to ask.
If you guys have questions, please leave them in the chat. Thank you. So we have a question. How do you think the junior doctor strikes are going to affect the waiting list, and do you think they should strike?
So obviously, junior doctor strikes will increase waiting times of the NHS, because they are essential to hospitals, even if they aren't able to take on larger roles such as those already trained. And whether they should strike, I I believe personally that they should have the right to strike. But with the strikes, since they've agreed to strike, they feel it is necessary. But obviously, the NHS representatives are saying that they should come to an agreement. So personally, whether they should strike, yes, in terms of pay, but whether this is the time to strike when there have been developments being made, not necessarily.
Any more questions? If not, please feel free to leave, and that will be the presentation over. Thank you. Right, guys, I don't think there will be any more questions, so you guys can leave now if you want. Thank you.
Thanks, Mustafa.